Good evening, everyone. It's so great to see so many of you joining us. I invite you to say hello in the chat and let us know that you're here. We welcome you all and thank you so much for joining us today. My name is Gina Zuckerberg and I am the Director of Family Programs at myFace. I'm pleased to welcome you to our program today. This program is designed to inform and educate individuals with craniofacial differences, along with their families and caregivers. We also welcome all the healthcare providers who have joined us for this webinar. But please note that continuing education credit is not available for tonight's program. myFace is dedicated to supporting the life journey of individuals with facial differences and their families by offering access to education, comprehensive resources, and community. We offer virtual support groups for individuals with facial differences and their parents. We distribute newborn care kits especially designed for babies born with a cleft and provide housing for families traveling to New York City for treatments. We strive to educate patients, families, and healthcare providers through programs like this Transforming Lives webinar series. We raise public awareness about craniofacial differences and choosing kindness through our Wonder Project School assemblies and our monthly podcast, My Face, My Story, where individuals can share their stories, be seen, and be heard. At myFace, we believe that the world is stronger when every person, no matter how they look, is valued, respected, included, and empowered to achieve their greatest potential. And now, to tell us more about today's program, I'd like to introduce my colleague and our moderator, Pat Shabara.
Welcome, everyone. I'm so glad to be here and for this wonderful program on Cleft Lip and Palate. I am really excited to be able to introduce our speakers, Dr. Roberto Flores and Meg Lico, who is our speech language pathologist. Both of them are on the cleft lip and craniofacial team, the myFace craniofacial care team at NYU Langone Health. I am delighted to introduce them. This is a pre-recorded conference that was done earlier, and they will be joining us later on, in addition to our myFace star Abby Rucker and her parents, Lori and Justin Rucker. So without further ado, I'd like to introduce Dr. Roberto Flores.
Thank you so much for the introduction, Pat, and for the opportunity to speak to you all this evening. Pat and I have known each other for a very long time, I think over 20 years at this point, and and at different capacities. And well, I'm very happy that I can continue this working relationship with her in her capacity now, working with myFace. This presentation is really going to go over our protocols of care. This is a required slide. We talk about our disclosures. I'm on the Global Medical Advisory Board for Smile Train, and I do some product consultation for KLS Martin. And this is just a little bit about me. I'm a director of Cleft Lip and Palate at NYU. I have been in that capacity for over 10 years now. And Cleft Lip and Palate really is a central part of my practice. This is really what I live and breathe. And all the plastic surgery I do is actually plastic surgery just of the face. I really don't usually ever go below the neck to do any kind of plastic surgery. But within the face, it's really Cleft Lip and Palate that's the heart and soul of my practice. And I've been at NYU for over 10 years, but I've been doing this type of work for over 15 years. And I do a lot of teaching and a lot of lecturing. I'm a program director here at NYU for Cleft Lip and Palate and craniofacial surgery, but also nationally and internationally, I'm really involved in teaching. I think this is a very fundamental aspect of certainly my practice and where I want to make a difference in this world. And then also working with Smile Train as part of the Global Medical Advisory Board, which is, and Smile Train, for those of you who don't know, is the largest NGO involved with Cleft Lip and Palate care internationally. Even though we're going to hear from a surgeon and speech pathologist at this talk, it's very important to understand that it really does take a team to do the work of cleft lip and palate, an interdisciplinary team. These are just some of the members of the team. And one of the great things that I like about the slide is see there's many of us, and you see the energy and the enthusiasm. But every single person in this demonstrating this slide really is a specialist, meaning that similar to me, uh, cleft lip and palate is the center part of my practice, the heart and soul of my practice. I don't do a lot of general, I do hardly any what would be considered general plastic surgery. The same thing with the members of this team. They've all become specialists. They all become experts in their own right. And really working with them on a daily basis is really, really one of the joys of my practice. I'm going to briefly go over the timeline of care for cleft lip and palate, and then progress to some patients that we've treated, and some aspects of care that are more maybe nuanced. But listed here really is a timeline of care in brief. And what I would first say is that everyone's journey, everyone's care plan is going to be personalized. And personalized for a couple of reasons. One is that cleft lip and palate can affect different people in different ways. Sometimes the lip is partially affected, sometimes the lip is affected and the nose is very affected. Sometimes the gums themselves are split or they're not. The palate itself can be affected in different ways or not at all. And depending on how all those different parts of cleft care, those anatomic parts that I've just mentioned, are affected, that can affect the medical and surgical journey. But then also the aspects of how the individual, how the family copes with these challenges, the different challenges that they face themselves, that is also very personalized. So even though this talk will give you a global look at what cleft lip and palate is, everyone's experience is going to be personalized to them. What I'm going to demonstrate here, and we're going to list here, is what we would do for someone who's affected with cleft lip and palate with a significant deformity of the nose and the gum or the alveolus is also split. That may not be the case with your child. That may be the case for you as an individual, but it's important to know all the aspects. So, in terms of multiple interventions, one of the first ones that we offer is a molding treatment in patients with a cleft lip. Now, that's in the form of something called nasoalveolar molding, or another innovation from our group called Plana, which is our form of NAM 2.0, which really is a more efficient and better tolerated form of molding. And what this is a way to fold the nose, make it look more like a nose, make the gap of the lips smaller, bring the gums together in a way to prepare a patient for a lip repair that will be better lasting, better results, less need for touch-up surgery later on. After that part, after that first part, we proceed to the cleft lip repair, which depending on the age of the child, we'll do that around 3 to 5 months of age, and we may perform a gum repair called a gingival periosteoplasty during that time. For patients who are affected with a cleft of the palate, we usually perform a palate repair at about 1 year of age. There are different times, there are different ranges of time in which a palate repair can be performed. Some people perform them a little earlier, maybe around 10 months of age or even 9 months of age. And if you look at the guidelines published by the American Cleft Palate Craniofacial Association, which is the national organization responsible for cleft lip and palate care guidance for this country, their recommendations is before 1.5 years of age. Now, we believe in our institution that that's a bit late because most kids start speaking around 1 year of age. So it would make more sense for the palate to be repaired before 1 year of age. But I think those national recommendations are something that you may read about, even though we like to perform them at or before 1 year of age. If the gum is affected, an alveolar bone graft is often required at around 8 or 9 years of age. And a lot of people sometimes don't understand what that is or what's the real intention of it. So when the gum is affected and it's split, there's a gap of bone. You don't have any bone there. And even though a child who will require an alveolar bone graft, they smile, you don't see that gap in their gum. And some parents and even some children think, well, why do I need this bone graft? And the explanation that I like to give is one where I talk about a tree, right? If you have a tree or like a plant or like a seed that's going to grow into a flower, let's say, it needs soil to grow, right? It can't grow in air or in space. And if you think of a seed growing as a flower, and you think of a tooth that needs to come out through the gum, you need bone for the tooth to come out and down into the mouth. If you have a space there, it will never come down. The same way, if you have a space, the seed will never go through to make a flower. Okay, so that's why we put bone there, so the teeth can grow, and you have a full set of teeth actually in your mouth. So that's the important thing about alveolar bone grafting. After that, some kids, especially if they're affected with a complete cleft lip and palate, this part of their face, their upper jaw, doesn't grow forward as much. And you may see this child on the your right hand of the screen, and the upper lip and the upper jaw seems to be pushed out a little bit. And now by putting a device called an anterior pull headgear, it can slowly pull the upper jaw forward a little bit, and that can help with facial balance and the way the teeth come together. But when the child then becomes an adult, some of the things that we think about, if needed, is jaw surgery. The person seen in the upper part of the screen, they're kind of extremely affected. Most kids aren't affected in a manner that this severe, but they need a surgery to bring the upper jaw forward. They may request a rhinoplasty to help the nose look better, and even a touch-up surgery on the lip. And once the face is done growing, we can do what is considered the final touch-up surgery, because we know that the face is not going to change that much from a growth standpoint. So that is the overview of what of the journey of cleft lip and palate surgical care is. That can sound like a lot, right? So a couple of things to state about that. One is that your child or you as an individual may not require all those steps, okay? It depends on what area of the face is affected. The other part is that amount of care, that arc of care, is given over the course of about 17 years. So it's not, one shouldn't have it in their mind that they're going to be continuously in surgical treatment. The concentration of surgery is really in the first year when we do the cleft lip and palate if needed, and when they're adults when you do the final touch-up surgery and the jaw surgery. In the middle, you may when they're about 8 or 9 years of age, you may require a bone graft surgery. Okay, and there could be potentially touch-up surgery there, but again, everything is individualized per patient. In terms of our institution, our treatment philosophy, of course, is to get the best results possible, and also to have your child look and function and sound like an unaffected child. So the example that I often give to to the families that come see me is that what I want is for my kids to pass a supermarket test. So what that means is that you're going to the supermarket one day when your child is about 7 years old or maybe 3 years old, and you're going to get some. You're in the cereal aisle, and someone passes you by and say, "Oh, look at this cute young boy, cute young girl," and then they go off to get some pasta, and that's the interaction, right? It's an interaction whereby they see your child as any other child, that they may see in the supermarket. And the experience isn't, oh, what happened, or oh, what's this, or did they have surgery, right? We want your child to run around in the playground and look like other children in the playground, right? So the supermarket test is like the school bus test, first day of school test, job interview test, right? First date test. And this is the goal of the surgery. That's the goal of our treatment plan. And also to affect this, to get the best results possible, having your child look unaffected and sound normal with the least amount of surgery. We at our institution, we do not embrace the idea of operating over and over again. I've had many patients who have come to me who were treated, let's say, in other places that have other treatment protocols, or read people's journeys, other patients' journeys online, whereby they're having surgery every year, every other year, in the hospital constantly. That is really not what we believe is healthy for for someone affected with a cleft or their caregivers or their family. We want them to have whatever necessary procedure they need, and then go and live life. And when they need another procedure, they can come back, of course, to see us. We will continue to see them for functional reasons, but operating over and over again, I don't think is healthy for anybody. We only do a single stage surgery. It's exceedingly rare that we will do any of these surgeries in a staged fashion. And I think that's also very important. And again, every place is a little different. Every place has a little bit of a different treatment protocols. But our unilateral, bilateral cleft lip surgeries are single stage. Our palate surgeries are single stage. And we think that's also healthier. We avoid prolonged surgery. The days of doing 8, 9 hour surgeries on children, I think, is from a bygone era. I think that's not healthy. There's a lot of good information out there to suggest that prolonged exposure anesthesia is not healthy for children, and we definitely believe that. And we also avoid some procedures completely. This is through doing high quality work, but then also through other procedures such as gingival periosteoplasty, which can avoid the need for alveolar bone graft in certain cases. Again, nasoalveolar molding is a fundamental part of our protocol. Again, and for us, this has evolved to Plana, and all it really is, the name I don't think is that relevant for the purposes of this talk, other than a molding treatment in kids who are significantly affected with a cleft to shape the lip and the nose prior to the surgery. If you look on your left hand side of the screen, you see a child who's severely affected with a cleft. This is the same child on the right side of the screen after a molding treatment. You see how the nose looks so much better. The lip cleft is more narrow. The gums are put together, and this child on the right side will really is better set up to have a longer lasting surgery and a better result without the need of any revisional surgeries. So this molding treatment was developed at NYU. We really have the greatest experience with nasoalveolar molding, which we've developed into Plana. And we continue to improve. We customize our approach. And through our customized approach now, using the Plana treatment, we've been able to do this with fewer visits, and it's easier for babies and parents. But the complement of this is something called gingival periosteoplasty, which is a gum repair that we can perform on some patients, not all of them, on some patients, in which by reconstructing, repairing the gum using certain techniques at the time of cleft lip repair, a bone bridge can form across the gums, and we can avoid the need for a bone graft surgery in about 50% of our patients. And again, we have a very large institutional experience using this, and we believe that can be in certain patients a very useful type of procedure. Many people have asked me what kind of cleft lip repair, and in this case, I'm talking about unilateral cleft lip repair. What cleft lip repair to use? What technique do you use? And there are essentially three. On the left side of the screen is something called a rotation advancement. In the middle of the screen is something called a fissure repair. And the right side of the screen is a technique I use, which is a cutting molar repair. And why I like this technique really is because the final scar is along what we call the filtral line here, and I think that hides it very well. But in truth, there is no best technique. What's most important is finding a doctor, a surgeon who is very, very skilled in whatever technique they choose to use. You could have a technique that you believe is excellent, but choose a surgeon who is not that experienced with it, and then that's not going to be helpful for your child. I like this technique. I have colleagues who are very skilled, very talented, who like other techniques, and that's absolutely fine. One of the things that's important that I feel very strongly about is that the nose needs to be corrected at the time of lip repair. It should be performed on all patients. And in the technique that I use, I'm not just moving the skin around, I'm actually moving the cartilages around in the child. And that's actually very important in my mind because it's a cartilage itself that gives the shape to the nose. And what I do, and I tell parents about this, is that you'll see that the nose sometimes is overcorrected. It's lifted up more than it needs to be. And there's intention to that because the nose will fall a little bit over time. So I think the overcorrection will helps my patients get very high quality, long lasting results that in which the likelihood that they'll need a touch up surgery for several years is actually pretty low. People have asked me several times, how do we get the best scar? I want to get how do how do you what are the things I need to do to get an excellent scar? One thing you need to know is that all the scar creams and treatments that are available for adults, many of them you cannot use in an infant, right? Any cream that you put on the lip, they will eat, they will ingest. So anything you put on the lip has to be tested in infants and safely to ingest. So a lot of the things that you would normally put on an adult for scars, you don't want to put it near the mouth of an infant. Okay, so I think that's a very important thing to know. But in terms of what are the other things can affect scar quality? Well, one is obvious the surgeon, right? You want someone who has a lot of experience, a delicate hand, and has a very broad repertoire in treating children with a cleft. The width of the cleft, the wider the cleft, the more difficult it is, of course, to reconstruct. The deformity of the nose. But the two other aspects that are really fundamental is how the repair is protected, because you as parents are going to have some role in protecting the lip. If you think of a scenario in which, let's say on my arm, I make a cut and put it together perfectly, but on a daily basis, I'm scratching it, and then I have the same other cut here and I don't scratch it, you can imagine which scar will look better, right? So there has to be some protection of the lip. And the third, and this is the part we can't control, is the biology of the child. And what that means is that everybody biologically makes a little bit of a different appearing scar. And if you think about it, that kind of makes sense, right? If we make the same kind of cut in the same place and different people of different ethnic groups, different ages, uh, uh, you could imagine that each one of those scars can look a little bit different, right? And that's a part that is the variable that we can't control completely. But those are the things that go into scar placement. And these are just some patients. I'm going to show a whole bunch of patients that I've treated through the NYU protocol. All these patients have had one surgery, no touch-up surgery, and these are big close-ups, so you can see the scar quality. But then also, you can imagine that a child who has this appearance, who's running around a playground, walking in a school bus, really probably would not get any kind of second glance. They would just see them as any other child in these social settings. And again, all these patients have had one surgery. These follow-ups are actually several years down the line. No touch-up surgery, a single stage a reconstruction. So certainly, it's very achievable to have a lasting result, a natural result for your child. Uh, you assuming that the right kind of steps are followed, and certainly there's variance, but in our group, in our following our protocol, when our kids reach about 7-8 years of age, I would say about 7% or less really are requiring any kind of touch-up surgery on the lip or the nose. And I think that's very important. We really don't want to have our kids, you know, undergoing surgery after surgery. So I've talked about the lip a bit. I'm going to go to the palate repair, and there are two procedures that are done to repair the soft palate, which is back part of the palate. The one I'm going to show here is called the furlough double opposing Z-plasty. Another one that is in very frequent use is called a radical intravelar veloplasty. Again, choosing one versus the other. What's really, if you look at the outcomes, meaning that how well they work, and you look at the literature, actually both of them have equivalent results. And it's really what it's really about, and what the literature shows us as well, is it's really about the skill of the surgeon. So I think although some people are very passionate about one kind of type of palate repair, some are very passionate about another kind of palate repair. If you look at the literature, they demonstrate equivalent results. I actually do both techniques, and I tend to do one type of technique for certain kinds of cleft palate repairs, and another kind of technique for another kind of cleft palate, the other technique for the other kind of cleft palate repair. But again, it's really surgical experience, institutional experience that is the most important. And without stealing Meg's thunder, our speech therapist, having a dedicated speech therapist working in the team, someone who is truly an expert, is the other side of this. And without that, I think that it'll be difficult to get the total care that is required. And this just diagrammatically shows the different steps of the procedure. It's 4 triangular flaps. It's a very elegant surgery, actually. This video, which will be, I think, demonstrated by the group, will actually show this surgery. So this is an animation that was created by one of my mentors, Cord Cutting, and we're looking inside the mouth. This is a virtual patient. And you see what we're going to do is elevate these 2 opposing triangular flaps, and they're going to be transposed across the palate. And then we're going to, on the underside of the palate, we're also going to have 2 other triangular flaps, which are also oppositely oriented. So 4 flaps all traveling in different directions during the procedure. And 2 of the 4 flaps will contain the muscle that's required to move the palate. That's called the levator veli palatini. And you see here, we're going to render the tissue transparent, and you're going to see that sling. It looks like a rainbow now. The sling of the levator veli palatini is reconstructed. And that's very, very important, because that muscle, that sling, is responsible for moving the soft palate so that it can seal the mouth from the nose when we're making certain sounds like pie or bye. That P and the B, all the air just goes right through the mouth. And that is a demonstration of the furlough technique. And then moving on from there, after we do the palate repair, we have a close follow-up, not only with your treating surgeon, but also our speech pathologist. Meg will give you a talk to follow mine, and there's something that you may hear about called VPI, and this is something that can happen in some kids after palate repair, in which air continues to escape through the nose, and in certain cases, this requires further surgery. So how do we prevent this? Well, one, you want a high quality cleft palate repair, right? You want the right kinds of technique with the right kind of team. However, patients with a wider cleft have a higher risk for VPI, and that's an important thing to know. So if it's a narrow cleft, if it's a partial palate cleft, then the risks are lower. If it's a wide palate cleft, if it's a more comprehensive palate cleft, then the risks are higher. But in our experience, about a 5 to 7% VPI rate. But a skilled speech pathologist is critical, not only for the diagnosis, but also to provide speech therapy and to perform a study called a nasoendoscopy when needed to assess palatal function. Nose revision. A lot of people ask me, should the nose ever be revised before the child is an adult, or when at the end of their teenage years? And the answer is yes, when required. It's a very important consideration at school age. Again, at our institution, the majority of our families opt not to pursue that, or the asymmetry is so minor that it's better to wait. And a lip revision can also be considered as well. But I definitely strive to do my best with the least amount of surgery. And again, revision rate for us at our institution is around 7%. I'm going to show now two patients who we've treated through our protocol. These patients have given permission to share their photos and their journey. This is a young child. You see that the cleft is quite wide, and the gums are separated. They underwent a nasoalveolar molding treatment in order to help fold the nose to a more symmetric form to help decrease the width of the cleft lip. They underwent a single stage cleft lip repair, followed by a single stage cleft palate repair. Um, the I'm going to show an animation that demonstrates this procedure. We're going to get the video up in a sec. So this animation will show in a very approachable way a cleft lip repair. And what to keep in mind that this is performed when a child's about 3 months of age. And what you'll see is that there is a lot of very tiny little flaps of tissue that are rearranged as part of the procedure. They also make a point to, as I mentioned before, to do a very delicate and careful dissection within the nose to help reposition the cartilages of the nose, because that's what gives the shape to the nose. And this is a very, very delicate surgery in which we're able to elevate the depressed nostril and the cartilages and to create a more symmetric tip to the nose. Again, we're raising these very small and precise flaps that it's almost like a three-dimensional kind of Tetris puzzle in which we're using your child's own tissue to help reconstruct the three-dimensional spaces that need to get filled. We close the floor of the nose, and that's actually very important because that will prevent air from escaping up into the nose just behind the lip when they're older. But then also in cases where they need a bone graft to the gum, this will help give them a better result. The lip is closed in a three-layer fashion. The inside of the lip, called the mucosa, that needs to get transposed to close that. You need that seal is very important, or else you can scar on the inside of the lip, and that can pull the lip upwards. And then you have to have a very robust muscle repair because you want to be able to kind of move the lip as you need to for feeding and for speech. And then finally, a delicate, very delicate and precise reconstruction of the lip. And again, in the technique that I like to use, I like to put the scar perfectly along, a thin scar, perfectly along what we call the philtral column. And I do believe that certainly in my hands and in my experience, that will give a kind of best appearance possible. We also put in very delicate sutures into the nose to help maintain the shape over the course of several years. For most kids who undergo this surgery, this is an outpatient procedure. And this baby now is a child. You see that the scar is virtually imperceptible in this case. The appearance is just like any other child that you might see in school. And these are just some photographs so you can see some of the more details. But this is just a lovely little girl who you can see, running around in any kind of playground, sitting next to your child in let's say elementary school or in kindergarten. And then she gets older. She required some bone graft surgery to the gum, to the alveolus. And now at the age of teenage years, about 16, 17, again, looking quite good. However, what we notice is that the upper jaw is pushed in a bit. And although not as obvious in the front view, you see on the side view, you see how the upper lip and the upper jaw seem to be pushed back a bit. You see that on the lateral view. So in this case, she needed a jaw surgery to pull that upper jaw forward. And in kids with a wider cleft, this is something that is more common. So we performed this jaw surgery called the Lefort 1. Then afterwards, we did a final touch-up surgery on the nose. And then afterwards, this is where she is after her completion of care. Really, a lovely person in all respects. I've really gotten to know her and her family. I've been very much involved with myFace, which for me is personally very meaningful in terms of giving back and being an advocate. And this is these two pictures for me says it all. Like the picture on the left is just this just just lovely, confident young lady. And this was an invitation for the wedding, which was recent, and this was an invitation that I received. And these are the things that really kind of give me a lot of kind of happiness in terms of my practice and the kind of work that I do. This is another child treated by me and my team. This child has a wide bilateral cleft. This is significantly affected. In this case, here you see nasoalveolar molding. The cleft ran in the family, so we had family members who were kind of reliving and experiencing their journey, which is something very real. Anytime people remember their surgeries, no matter what they are, and I think that's something that over doing this kind of care over time that I've learned to definitely respect. And this is a child after a single stage cleft lip repair. This is our last fall with me. Just a lovely young girl, lovely family. Um, we'll be setting her up for a bone graft at some point, and this is what we like to see. And no touch-up surgery on the lip or the nose, to date. I'd like to kind of end off with touching on a couple points. One is that uh, the way when you think about this surgery, it is a very delicate surgery, lip and palate surgery. It's very delicate, very precise, and something whereby that first surgery on the lip and the palate is so important, and you really want to get the best results possible. And one of the things that I've been working on is to really create ways for surgeons who are maybe a bit less experienced or who are just developing their practice in this, to find to improve their technique in safe ways. And I've worked with different companies to help promote the use of these kinds of models that are great for teaching and for people who are kind of on the lesser experienced side to practice these surgeries. And I think this is very important. And between the animations that I've shown you and the use of these models, I've worked not only nationally but internationally. You see this conference that I hosted in South America, in which we had other surgeons working with models. We have other experts looking over their shoulder and really helping them get the best results possible. And this is such I think, an important part of the service that I do. The last thing I want to talk about is just surgeon selection. This is something that I'm asked to touch upon for parents. I think this is a very important decision, but I think, one, don't just look at the surgeon, look at the team. Okay, this is a team sport, so to speak, and I don't do all the work. I only do part of the work. And I think looking at the quality and the experience of the orthodontist, looking at the quality experience of the speech therapist, of the social worker, of the dietitian, of the nurse practitioner, are they working together all the time? Are they people who are scattered all around the area? I think that is so important. Look at the photos. Any surgeon of any experience should be able to show you photos of the patients they've treated, as I just did in this talk. And you can also talk to other families treated by the surgeon of the team, because they will know the protocols. They'll understand the protocols. Every team, every surgeon is a little different in how they do things. So just because you've read about someone's journey online doesn't necessarily mean that that is the journey that your child may have treated by this team. Okay. And I think looking at social media is important, at least in terms of assessing your surgeon, right? You have to see how do they show themselves? Is this something that they live and breathe? What is the surgeon showing? Are they showing a lot of this kind of work? And also, what are they not showing, right? And I think that's also very important, because If you get a sense that their real area of interest is another kind of plastic surgery, well, then maybe that should tell you something, right? So I think those aspects are very important for you to inform yourself. Thank you again for your attention, and I'll hand it over to Meg.
Thanks so much, Dr. Flores. I really am thankful to be part of such a great interdisciplinary team. Today, I will be speaking about speech and feeding considerations throughout the lifespan for children who have a cleft lip and palate. So we're going to start here with feeding. We know that the prevalence of feeding difficulties is about 72%. I would say that maybe is even a little bit higher. Children with cleft lip and palate usually do need supports from an interdisciplinary team in order to thrive. But the good news is that a lot of our babies can feed successfully with the appropriate accommodations, which I will discuss in just a bit. So a lot of our kids can feed safely and effectively. Our priorities in the first year really are about weight gain, because we know that we want them to be healthy and a good weight for when they undergo their 2 surgeries in their first year of life, right? Lip repair and palate repair. We also want the feeding to be safe. So when we talk about safety, a speech language pathologist, in some states, occupational therapists would be assessing the safety, meaning is the food or formula or breast milk going down the right pipe, right? And so as long as we're feeding safely and we're gaining weight appropriately, we can proceed with those surgeries. So we're really there to help support their journey before and after their surgeries to help them gain weight and be a happy and safe feeder. Why is feeding so difficult for our kids? So I kind of broke this down. There's kind of 3 components here for feeding. The first is when you have a cleft lip, it really is difficult to maintain what you guys as parents might, know as the latch. We refer to it as speech pathologists as the labial seal around the nipple, meaning do they have a really good kind of seal, meaning like it really closes off either around the breast or around the nipple of the bottle. So that's kind of the first difficulty that we sometimes run into. Obviously, you saw some pictures of some wider lip clefts. So you can imagine the nipple of the bottle is a little bit difficult to maintain a good latch when you have that opening. The second piece, when you add in, a presence of a cleft palate, is the difficulty to compress because you don't really have like surface area on the roof of your mouth because you have that opening, right? So there's not much to compress against. Now, again, we do try and figure out some modifications for that. A lot of our kids, we utilize the vomer bone, or we might angle the bottle ever so slightly, which again, I'll talk about later. But essentially, there's some difficulty there in the ability to compress against what another baby might be able to compress against the roof of their mouth. The last piece, and probably the most difficult piece when you have a cleft palate, is the inability to create suction. So anytime, especially when you draw milk from the breast, you need to create negative pressure to draw that out. And so it is really difficult to create negative pressure and suction because you've got this opening from the nose. So I describe it as if you were drinking from a straw, plastic straw, and I encourage you guys to try this on your own one day. But if you poked a hole in that straw, kind of resembling what a cleft palate might be, and you try to suction water from that straw, it becomes very, very difficult. And it actually kind of tires you out the more you do it. And so that's why some of our kids in infancy have some difficulty at the breast or the bottle with like a typical baby bottle, because they cannot get that creation of that negative pressure, which we all needed as babies. There we go. So what can we do about it? So there are great bottles on the market. I've listed 4 here that have kind of evolved over time. I know Pat always tells me the history of kind of the bottle creation, which is so nice to see the evolution of these bottles. Essentially, the bottles we really want to be child controlled or baby controlled, meaning that the child's in control of the feed, because it is really hard for parents to have to try and guess when that baby is ready for their next kind of spurt of milk. And so we really love the Dr. Brown's at NYU, but we also love the Pigeon. It really depends on the child, the size of their cleft. The most important thing are these blue valves that you see on the right side of the screen. Those can be inserted into a Dr. Brown's bottle, and that actually helps with that issue I mentioned in the last slide, which talks a bit about the negative pressure. That kind of addresses that inability to create the negative pressure. It's a one-way flow valve. And so it really helps the child to work smarter, not harder, when they are drinking. We also might adjust the nibble placement in the mouth depending on what type of cleft lip they have. We might change their positioning, the upright positioning, kind of like you see with this little guy. It is the common kind of recommendation as it stands. There's certainly more research coming out for other positions as well, but that kind of helps to reduce any kind of milk coming out through the nose. We know that our kids swallow a lot of air because of their cleft lip and palate, which can lead to a gassy baby, and a gassy baby is an unhappy baby. So we recommend burping frequently. We always talk about timing. And let's say we do all of these and we're still not seeing the growth that we want to see. Our dietitian, who I'm very, very lucky to work with, will support the families in terms of supplementing with formula as needed. As a lactation counselor, I'm always pro breast milk, but we also want to make sure that the baby is gaining appropriately because we do have these 2 big surgeries in the pipeline. And so our dietitian will work with the families to develop any kind of formula fortification as needed. And, with these modifications, most of our kids with cleft lip and palate can feed and feed well and, prepare for surgery. There are times, however, when we do have kids who have a little bit more difficulty than others, whether that's due to a non-cleft related reason, or maybe they were born prematurely in addition to their cleft, et cetera. So in that case, we would refer over to other disciplines. So at any large children's hospital system, you're going to have some kind of feeding team. We're very lucky at NYU to have the NYU Rusk feeding team, who we can refer over if we feel like the problems have now extended beyond kind of those simple cleft-related difficulties. If we're concerned for reflux or anything like the allergies, we might refer to GI. And so certainly it really does take a team with feeding. I'm the only one presenting today, but everyone should know how important it is. And I'm not the only one doing the feeding. In fact, our nurse practitioners and dietitians are a really massive and important part of our team, and we really work together to try and figure out the best plan for our children. So then, what happens when our kids are going through surgery? In infancy, we do speak with the families about what starting solids looks like. It's really exciting part of any parent's journey, right? But we do know that there might be some modifications that you make when you're starting solids with your child, including what foods to offer. So for example, we might want to avoid spicy foods before cleft palate repair because it could irritate the nasal cavities, things like that. And so we would discuss that in infancy. Also, every cleft team, similarly to what Dr. Flores said, every cleft team has their different recommendations. Every surgeon's a little bit different. Unfortunately, there's no kind of universal parameters on a lot of things in cleft care. And so the post-operative protocols for your team might vary, meaning what can they eat and what can't they eat after surgery, right? Do they need to have a special bottle or cup after surgery? Can they only take purees and liquids to facilitate surgical healing? And again, I can't underscore this enough. Utilizing the interdisciplinary team is really crucial. So our nurse practitioners are amazing in preparing the families for what to expect after surgery. And our dietitian will also give guidelines. So you see here these yummy smoothies, which I'm sure many of our kids are sick of at this point, but it does help facilitate surgical healing. We've also done research at NYU to look at what is effective in terms of post-operative diets. So there is some research now out from our team to support bottles after surgery, after palate repair, and allowing kids to go back to their preferred bottle for comfort purposes without kind of impeding the surgical healing. And then in terms of speech and language, we know that with feeding, the first year of life is really important, but and honestly beyond, but really the speech and language comes into play around 18 months. It really is before then, but I would say you saw the timeline Dr. Flores put out there. And I would say I am involved more so for feeding in the first year. And I do meet a couple times in the first year about language, but really it's so important that our kids get speech and language evaluations, follow-up, and therapy between 18 months and 7 years. There's kind of that gap between surgeries. So you heard Dr. Flores talk about the palate repair and then alveolar bone grafting around age 7, 8, 9, 10. And so there is that big gap, and that's really where the speech and language comes into play. So we know from the research that about 50 to 70% of children who have a cleft palate will need speech therapy by preschool age. This number is much lower if the child only has a cleft lip, but for the purposes of our webinar, since we are speaking to cleft lip and palate, I'm going to go through kind of the trajectory for both conditions. We do know, and this is great news for parents, that the earlier that we address the concerns, the easier they are to correct. And there was actually a recent study that came out that showed that the earlier you initiate, the better. And a lot of kids who needed that speech therapy by preschool age were able to finish by age 5, as long as they were proactive about it. And so there is a bit of like old school thinking sometimes of, oh, maybe they'll grow out of it. But the research actually shows the exact opposite for any child with a speech or language condition, and especially for our kids with cleft. And we know that speech therapy is effective. You can see some of the studies that I cited here in reducing these errors. So I rely so much on the surgeon to get the structure right. And I'm so thankful that I have great surgeons at NYU. But then it's really my job to get that function working correctly, right? So he can repair the structure, the palate can look as beautiful as ever. But then it's my job to teach that child to unlearn some of those habits that they maybe picked up early on. In the first year, like I said, the feeding is really the most important thing as we prepare for those surgeries. However, we do discuss babbling quite a bit, and we do discuss language expansion. I don't want to go too much into this today because I've done actually a prior webinar with myFace that is available on their website via recording called Early Speech and Language Development in Children with Cleft Lip and Palate. This was done with my colleague Lauren over on the West Coast, and we kind of really went into detail about what to expect for early language development in the first year. I would say that hearing is also a really crucial part of a cleft team, so making sure that you have access to audiologists and ENTs in case any ear tubes are required or any hearing aids or anything like that. Most of our kids with the ear tubes can do really well and don't require additional hearing aid or like supplementation. But it is something that we want to be, again, proactive about, because the hearing shouldn't impact the speech as long as we're proactive about it. If we're not, that's when it can start to impact certain speech sounds and our resonance quality. So I highly recommend checking out that webinar. Okay, so now we've gotten through kind of the early stages, right? We got through feeding, we got through early language expansion, and now your child's cleft lip and palate have been repaired. Sigh of relief for the time being. And now really is when I get involved. So one of the most important priorities is speech and language development from the time of palate repair, once your child's healed, all the way through up until they really begin orthodontic care. And so there's a lot that we look at. One of the big things that comes up on Google a lot, or my parents will tell me they saw on Google, is something called velopharyngeal insufficiency or velopharyngeal dysfunction. We do want to work first on all of the things that we can address through speech therapy. So a lot of things parents will think is VPI, but it's actually what we call a compensatory error, meaning that it is something that's like more like a habit that we want to just break in speech therapy. For example, sometimes children can push air through the nose because that's what they were used to in infancy. And so we can undo that in speech. The earlier, the better. And then once we kind of mitigate all of those compensatory errors, we're left with what we call obligatory errors. And it makes sense, right? The word you're obliged, or it's an obligatory error, meaning it's not something that the kids can really fix. And those are the types of errors that after we fix the compensatory errors, we would, look into orthodontic or surgical management. We'll talk about orthodontics in a bit and how that kind of comes into play. But in terms of these obligatory errors, you might hear excess nasal air through the nose, which a good speech therapist would be able to tell you if that's compensatory or obligatory, meaning that they can't help it. In which case we would be looking out for what we call velopharyngeal dysfunction, otherwise described as nasal speech, kind of on Google a lot of the time. So you'll see to the right, it's a little small, but you'll see that these letters, sounds really, they're not letters, but these sounds are all made in different parts of the human body. And so there are some that are made down by the throat, there are some made in the mouth, and there are some made through the nose. And so certain sounds, like Dr. Flores mentioned earlier, really need that intraoral pressure, like we've been talking about for feeding as well, but really need that intraoral pressure to produce. And so when we have this leak here in the back, it's really near impossible to make those sounds correctly. And so, again, having a speech therapist is really important, especially a speech therapist who's trained for cleft, because these are distinct errors compared to what other kids might kind of experience. So kids with language delay, phonological processes, autism, they're going to have very different errors than our kids with cleft might have. And so it's important that, again, you have follow-up and evaluation for this issue. Essentially, with velopharyngeal dysfunction, there are 3 different types. And I really love this this image from the Informed SLP, and I'm thankful that they allowed me to utilize it today to show you all. So when we have normal velopharyngeal function, we have that palate that our doctors have repaired beautifully, thankfully. And it basically acts as a door between the mouth and the nose. So oropharynx, meaning back of the mouth, nasopharynx, meaning the nose, nasal cavity. And so the door is open when we breathe, right? Because we want to breathe through our nose. And also when we make sounds that we need our nose for, like M or N, those are all sounds we actually purposely push through the nose. And then the door is supposed to close for swallowing. And then any of those sounds that you saw listed in the last slide for production in the mouth. And so we call those oral consonants, meaning consonants made in the mouth. Most people, this is how the door works. But when you have velopharyngeal dysfunction, that door is not working properly. Now, why it's not working properly is up for a speech pathologist to figure out. So I'm going to start on the right side here. This VP mislearning, velopharyngeal mislearning, is what I talked about earlier. It's that compensatory error where children are actually pushing through the nose, or maybe not realizing they're pushing through, but they're letting the air go through the nose or through the door when they shouldn't. And that's a learned pattern. And that is something that if I'm hearing that and I'm testing for that, I can fix with ongoing dedicated speech therapy. Velopharyngeal incompetence, on the other hand, is when the door doesn't get the right signals to open. So these are often due to neurogenic causes. More so like a traumatic brain injury, apraxia, stroke, et cetera, et cetera. And then the final, and probably the one that you guys have heard about the most, is velopharyngeal insufficiency. And that is when, even though the door is working properly, it's just a little bit too small. So the length is not there. And so you can see here that even though the door opens and closes correctly, there's still air that's escaping up through the nose. And that is due to, again, the palate can be repaired well, but it's really due to the structure not meeting where we need it to meet. And so that is velopharyngeal insufficiency. And that is when we would refer for a scope, and we would have ongoing discussions with our lovely surgeons to figure out what we can do. We would do that hopefully around, the earliest we do a scope would be 4 to 6 years of age. In the other webinar, there is actually a video that I mentioned. It's on YouTube. It's called A Firsthand Look at Nasoendoscopy, and it is through NYU. And your very own Dr. Flores is getting scoped in it, which I made him do. And so you can take a look at that video if you're hoping to learn more about what that process looks like. There are certainly different types of ways to evaluate for velopharyngeal dysfunction past just a nasoendoscopy. That tends to be our surgeon's preference for getting some imaging, but certainly there's also video fluoroscopy and MRI. So whatever your team decides to do, again, making sure that you have a really good partnership with a full-time speech pathologist who knows cleft really well, and then the surgeon, and making sure that they're communicating correctly. Because the worst possible scenario, and I'm just going to go back a slide first, is that the child actually has velopharyngeal mislearning and ends up getting some kind of surgery when it's not truly velopharyngeal insufficiency. And unfortunately, we have had people come from other centers where that has happened. And so again, communication is key here. So then once we get to adolescence, so we've gotten through kind of that VPI management, hopefully, and then we start to talk about orthodontic management. So with orthodontic management in adolescence, you saw some of those pictures where there was a difference in bite, right? Or difference in jaw, a discrepancy with the upper jaw and the lower jaw. So that can affect certain speech sounds and cause obligatory, again, obliged distortion. So kids cannot help that error. We do our best in speech to try to get it as functional as possible, but sometimes it's different. So we do want to make sure that we're also collaborating with our craniofacial orthodontist. Sometimes their orthodontic intervention helps a lot. Sometimes there's a temporary distortion with the speech, depending on what appliance they put on. But then I counsel the families saying that long-term, this will actually help the child with their speech. So we do really collaborate when the kid's older, between 7 to 10 and beyond. And then Dr. Flores spoke about one of the last surgeries, which is a jaw surgery. And so with any maxillary advancement surgeries, there can be actually a lot of speech changes. Some are speech changes for the better, and some present risks. So risk for potential velopharyngeal insufficiency after surgery. And so it's really important that you have a speech therapist doing pre and post-operative evaluations on these now young adults, which is crazy to think about, and making sure that we're counseling families appropriately so that they can make a decision on if they want to move forward with surgery. And so I'm very big on, patient autonomy and involving shared decision making. And I know Dr. Flores is as well. I'm never pushing for a family to get, or a child to get VPI surgery or jaw surgery if we feel like they feel their speech is functional. There's certainly a degree of VPI, and there's a degree of these types of errors. And a lot of our kids maybe don't have what's considered the perfect speech. But I would argue that perfect is a continuum, and that if the child is happy socially and academically, why would we, push them for more surgery? And so we involve the entire family, and we have a lot of discussions before moving forward with any surgeries, speech or otherwise. In summary, having a well-trained full-time speech and feeding therapist is a really integral part of an interdisciplinary cleft team. There are a lot of cleft teams that might just refer out for speech. And unfortunately, the way that it's set up in the US, the United States, there isn't a mandatory course for speech pathologists on cleft and craniofacial conditions, and a lot of graduate programs, which is very unfortunate. But that is the climate that we're in right now. And so I was very lucky to have a wonderful mentor at Columbia, and a course that was an elective that I opted to take back in my graduate years, way back when. And I really grew to love this profession. But there are a lot of speech pathologists who have never taken a course on cleft, and they're absolutely well-meaning, and they probably are experts on other things that I'm not experts on. But it is important when you're looking for a team, when you're having prenatal consultations, to discuss what opportunities you have to obtain speech therapy and feeding therapy, and what that looks like. So again, I just want to thank you all for having me, and I'm happy to answer any questions.
To Meg. And that was just a wonderful presentation. And Meg will be joining us along with the family that I'm going to be introducing you to, as well as our Director of Family Programs, Dina Zuckerberg. Unfortunately, I just heard from Dr. Flores, and he is stuck in the operating room. He had an emergency case that came up, And but for any of the surgical questions that are being posted, and there are so many questions, we are not going to be able to get to all of them. If you would submit your question to us at myface.org, we will get back to you. I will have all of the specialists look at your questions and get back to you. So I am now really, really excited to be able to introduce a remarkable young woman. She's just a myFace star, and she's been a member of the myFace community for many years, as well as her parents. This is Abby Rucker, and Abby recently got married, so it's Abby Pexton. And I have known Abby since before she was born. She was followed by our team prenatally, which I'm really happy to report that, and I was just speaking to Meg about this, that about 75 to 80% of our babies are detected with a cleft lip and palate prenatally. And I'd love to speak with the Ruckers about the impact of that on them. And I am just so excited to introduce Abby and her parents, Lori and Justin. I just want to give a quick background. Dr. Flores featured you, Abby, in his presentation, which I thought was great. It also brought up a question that I have for you, but the journey that Abby took, and Abby and Lori and Justin took, was quite incredible, quite unique. And I just want to say really quickly that when Abby was born with a cleft lip and palate, a unilateral cleft lip and palate, she was a baby who on 9/11 underwent her cleft lip repair while the Twin Towers were falling down. And I will never forget this. I will never forget coming out to her parents, telling them that the surgery is going to proceed and everything is fine. So, and then your journey continued. So I just want to welcome you, Abby and Lori and Justin. I feel like, we've had such a close bond for all these years, and it's such a joy to have you join us. Thank you so much.
Thanks for having us.
So first I wanted to just, there was a comment, Lori and Justin, from a grandmother, and I don't know if you saw that comment in the chat, a grandmother in Michigan who's going to be the grandmother of twins, and it sounds like one of them is going to be born with a cleft. And I wonder, and it's been such a joy to work with grandparents because, of course, they're so concerned about their child and, of course, their grandchildren. And I wonder what thoughts you might have, or advice or reassurance that you might have because you experienced a prenatal diagnosis.
I'll say it was wonderful to be able to find out as much as we could before Abby was born, and it brought a lot of peace to us. And I think getting the opportunity to years later, having been gone through this process and all of the different surgeries and treatments and therapies that we've been through, I just have to underscore what's been said tonight. When I made that phone call and talked to you for the first time, Pat, I remember just feeling like this feeling of we've got you. We've got you. And something that was talked about tonight often was we stepped into a team of specialists. And I felt like your job were specialists in your own field, but you were training us to take the role of specialists for our family and our child, and to train Abby ultimately, and we can see this happening, to be a specialist of her own care. And so I have to say, even though a lot of it was, we're talking a lot about physiological things and things that are happening and the way that we can care with different bottles. I remember the Haberman bottle, that's what we used. But if I can just give a perspective, there's so much hope to be had. And the process, I think, was a refining process for us as well for Abby, that has helped her grow into be this just beautiful, kind, giving, compassionate soul. But I do have to credit, and I see, hi Carol, and I see, we're so grateful. This is we didn't just join a team, we joined a family. We are comrades in arms, and I could go on, but I know we don't have much time, so let's let you.
just wanted, Justin, any other thoughts before I jump to Abby?
You know, one of the things that everyone said is when children come with a special, something special about them, there's really, truly something special about them, and they find it, and this team and helps them to find it. And getting through life is never easy anyway, and this allowed our daughter to just, I don't know, flourish. There's something special that comes along with them when they have something they need to go through, and this was powerful for us to learn and watch.
I was thinking, Abby, as I was listening again to Dr. Flores's presentation, specifically about you. He was, showing your photos and talking about your imperceptible scar. And yes, you scarred beautifully. There's no doubt. But what was interesting, and I'd love for you to talk about this, is that before we went on the air, you were actually talking about some of the challenges that you did have. And I think we should talk about that a little bit, that, the surgeons and the team do their very best to quote, normalize your appearance, whatever that actually means. But talk a little bit about, some of the challenges that you had, and just sort of what advice do you have for kids and for parents that are maybe a little earlier on this journey?
Well, there's so many things that can be said about anyone who has to go through a growing up with something different about them. It's difficult. There's no sugarcoating that. And I definitely had a tough experience in school sometimes. And I know, and I'm thankful that my parents have always been the advocate that that those around us, if they don't understand, they aren't necessarily going to respond the way that you hope they would. My mom used to say, assume noble intent. So I know that those who have said things to me in the past that hurt me, I've chosen to believe that they did not intend for that to be the case. But I remember at school having people say things to me about the way that I ate food, saying that it was a little strange. And that was back in, I want to say 4th or 5th grade, that comment was said to me. And I remember for a few years, I really struggled with eating in front of those that didn't know me well or people that I liked. And it got to the point where sometimes I would throw away my food at school. And I would lie to my parents about eating. And I'm not proud of that. I wish I'd been a little more kind to myself and had asked my parents for help or brought it to their attention. But in the end, and I think this is the most important thing about anybody who has to undergo having a cleft lip and palate or knowing somebody or being close to someone who is experiencing having that, patience is so key, because like anything else, you're going to experience something. It's going to be hard. You're going to have moments that are dark and you're going to feel alone. But those little moments over time of connectivity and hearing those words that there's nothing wrong with you. Sorry. And hearing,
It's okay.
just hearing from people, you are beautiful and there's so much more to you than this. And this makes your experience powerful. In the end, I am who I am now because of those comments and because of those who are brave enough to tell me who they know I am. And I'm so grateful that I had plenty of people like that in my life. And I'm married to someone right now who is who is just so kind. And just I'm just so grateful. Your words matter, and I, as a child, to parents, just be there. Your support, your constant and consistent support. In the end, it matters so much more than you may realize. Just existing, just being there, is everything. I don't even remember what your question was. But I hope I answered
Well,
it.
that was amazing. You are exactly who I have known you to be. You're just, wonderful, compassionate, kind person, just as your parents are. And I wonder, Justin and Lori, listening to her, if you can speak, what, any thoughts on this? And also, as we're, I'm not sure exactly what my audience is here, what our audience is here exactly. I think it's a range. But for me, I really want to make sure that we are getting a message out to those who may be just starting this journey, like the grandma who, and I'm so happy that you joined us. And I'm sure that there's some others. Just listening to Abby and just thinking, just about your own experience, I wonder what were some of your challenges and what advice might you have for those, on the road?
It's like, well, gosh, I've thought a lot about this, and but I'll try to be brief. But I remember when we started the journey, I was so focused. I was a brand new mother, and I was so focused on the physical care and kind of the ins and outs of every day. How is this going to work? And I think we both poured ourselves. I remember having a ritual that we'd have in the morning and the evening as we were changing her tapes, and that Tegaderm, I think it was called, and her,
yes.
Making sure her skin had time to heal. And one of the things we kind of missed out on was, because of the plate, not being able to really nuzzle and snuggle with her. So we, at night and in the morning, we'd put on some classical music or whatever, just nice music, and we would take that time when her tapes were off, and we would hold her close, and we would try to compensate that nurture, that care that the other team of specialists, you all gave that to her. That was what was amazing. But we had that day-to-day nurturing care. And I feel like we did the best we could. If I could go back and say, relax a little bit, my job is to observe and discern what is needed, and then do my best to give what we can as a team. And then I think in her later years, the necessity to counsel together as often as possible, to talk to each other, because Abby talked about the food. And I remember we went to Chick-fil-A, and I was kind of frustrated, like, why aren't you eating, the sandwich? And then I remember she sort of shut down. But we have made it a point to talk to each other, and since then we've talked about these things, and and we still do, and it's a journey. But I feel like that is a critical part of care for a parent, is that know that it's going to be individual, but as we observe and we create a safe place, a loving place, that really, it's kind of an exciting journey. If I know some of you might say, please don't say that, but it can be exciting because we're learning together along the way, and we're creating these really deep bonds. And honestly, I would never have dreamed Abby's pathway went the way it went. But I'm grateful for the struggles that we have. I'm grateful for those. And I'm grateful the way we've been prepared for them. What would you say?
I think it's just taught us all a lot. I mean, we've learned a lot, and we've learned a lot about life, and just powerful that when you are there for support and you come into a team that also gives the support, and then you have friends who are going through the same thing, that you go to the place and you get support from them too. This is one of those situations that's treatable. And I think very fixable, obviously. I mean, look at, if you're talking about physical, but the spiritual part and the emotional part is also a journey and fixable. And as we're learning, we're growing to even create that to be more wholesome and good. And we were just so proud of Abby. I mean, I look at her wedding photo and I knew this was a month before she went in for a surgery to remove one of the screws in her nose, so she had a big bump on her thing, but she didn't care. She was at her wedding and she didn't care. She had already gone through all of this with her face. Look at her.
Oh God, I wish I could have been there. It must have been amazing. Yeah, I just I have so many thoughts about you as a family, and I'm so grateful that you shared this. Thank you so much for sharing this. I want to thank Dr. Flores and Meg and Abby, Justin and Lori for their presentations. We have so many questions. We're not going to get to all of them. And so, as I said, please, we have your questions. We would love to try to answer them. I want to have Meg come back in. Meg is here with us, and also Dina as well. At this point, we just again have so many questions, and I'm sorry to those who I can't get to all of yours. But I just wanted to tell you, Abby, that from Marley Eugenio, she said, Abby, I was born in 1973 with a bilateral cleft lip. You are 100% right. Words do matter. And so, thank you for that, Marley. I think that, that's one of the things that I've learned over the years as the nurse practitioner is words do matter. And, I think we have to keep that in mind as we talk about facial deformities and, anomalies. We all have differences, and I think that's something to think about. So let me just go to a question. Meg, I have a question. I have a lot of speech questions, and I'm going to send you more after. But one of the questions, and we've heard this a lot over the years, is about feeding. What can we do to help with feeding? And so this is a question from Richard Mungo, and he says, with very difficult feeding situations, do you use feeding obturators? Do you find that those infants undergoing NAM therapy have less feeding problems because they have something to compress the nipple and direct fluids to flow appropriately? This is a great question, and we get it all the time.
Hi, everyone. Yes, thank you so much for being here. Thanks for the question, Pat, and great question from Richard. At NYU, I've been lucky to observe both NAM, which is when I started what we were doing, and then later the evolution to Plana, which does not utilize a plate inside the mouth. It's external only. And so I've been able to see the differences. One of the things, and I don't know if we can pull up my slides that have the kind of stages of feeding, and it's kind of like a 3-layer slide. I don't know if that's possible, but if it is, one thing that feeding obturators can help with is compression against the nipple, because it adds that surface that wasn't there prior if you have a cleft palate. However, it really doesn't solve the issue of the suction. So in that kind of 3-tiered approach where you've got the labial seal, the compression against the nipple, and then the intraoral negative pressure generation, it only helps with the compression piece. It doesn't help with that last part, and that last part's actually the most important part. So while there are a few case reports in the literature from different countries that support a feeding obturator, there's not a ton of high-level evidence to suggest it. And we've actually seen, I've had a few kids come from other centers where they've come in with a feeding obturator, and, there's no one size fits all. So just if you've ever had a child who's had a feeding obturator, I'm not saying it was bad or wrong. More so what I'm saying is that in my clinical experience, I've seen it sometimes do more harm than good. For example, if it's not fitted properly, the family might have to come in for a lot of repeated adjustments. I'm not sure if the Ruckers have any insight into that, and the number of trips in the early years. It can be a lot on families. And then on top of that, kids can also experience quite a few sores. I have an SLP colleague whose child was actually born with a cleft palate, and they had to go back to the center a lot, the center team they were going to, for readjustments to the NAM plate, because he kept getting sores, which would actually make him refuse the bottle because he was uncomfortable. So I think with any kind of treatment planning, there's no one size fits all approach, but I haven't seen a high level of evidence enough to support me wanting to advocate for that for all my patients, especially knowing it doesn't fix the primary issue, which is that suction piece. But I have had interdisciplinary conversations with like SLPs in other countries where they do utilize it more. So not knocking it, but we've seen more success with some ongoing feeding support with an interdisciplinary team, dietary, myself, NPs, etc. Pat, I don't know if you want to add anything since you are also a feeding guru.
No, I think it's really true that, that an obturator, yes, can it help with compression? But I found in my experience that it was more annoying than anything for the kids. And I don't really think that in the end, I think a lot of the families that came to us who had obturators, it just really, in the end, it really wasn't really working well to deal with the issues, the side effects that they were having. And so I agree with you, Meg. So let me just say there is a surgery question that I think I can answer. Maybe I guess after being the NP on the team for 34 years, I can answer some of these things. But Pauline asked, how many surgeries would you need after a definitive jaw surgery as an adult? Are all patients mainly done after the jaw surgery? Is there any touch-up that may be required after that? And, I think as Dr. Flores said in his presentation, every single patient is different. And along the journey, there are patients that once they have their jaw surgery, they may be fine. I think that usually what happens is that once we do the definitive jaw surgery, once a patient has fully grown, and the reason that we do that is if a child is not fully grown and then we do jaw surgery and then they have more growth, you may need to do more surgery. So we're very careful about evaluating for final jaw surgery. What often happens is once that final jaw surgery is done, I would say there are a lot of patients who then elect or decide to have nasal reconstruction. Some of them have it before jaw surgery, and some of them have it if they don't need jaw surgery. So that is a surgery. I would say that is the one surgery that most patients are very happy to have. That's the surgery that they ask for, both for a deviated septum, which a lot of our patients have, but also because aesthetically they would like to, they've gone through a lot, and for those who want to have, feel better about the way that their nose looks, that's something that's available. The other thing I would say to Pauline is that a lot of adult patients have dental challenges. And I know that Dina, we've had a lot of adults who have had dental challenges in terms of needing prosthetic work. And that is something that we know. And Dina, you might want to just say a word about that we know that's a big challenge for our patients, for our adult patients.
Yes, definitely. I hear it all the time from the adult population, how hard it is to get the care that they might have had when they were children as they get older, and the access to it in the same way.
Yeah, exactly. And I think that's one thing that we in the American Cleft Palate Craniofacial Association, and certainly in myFace, we're really trying to listen to adults and what are those needs that are not being addressed. And I think Lori and Justin, we talked about this before we started, that orthodontics, even though we had an orthodontic team right in our location at NYU, orthodontics was a challenge as Abby got older. Do you want to just maybe say a word about that?
Yeah, I think we got a little scared of leaving you all because we moved away from New York City to Florida, and so we were trying to find someone that was connected, and ultimately we just had to search out a good orthodontist, and because at that point the care wasn't as necessary to be with for those few years. We found that for Abby's care, she was okay, and we still stayed in contact with the team, and we never really left. But we found that trying to keep it, we ended up having to drive really far away, but we found a really great orthodontist eventually that saw all of our children.
And that had worked with the team in New York, or was willing to talk to them.
That's right. Was willing to kind of, I think the team before, it was a little bit, there was some maybe professional, I'm not sure what happened, but it didn't work, but we had to keep searching, and eventually we did find a great orthodontist.
Yeah, I think that, that certainly is the big challenge. I wonder, Abby, for you now you're an adult, and you're used to, and I think it's really hard, and this is one of the things that that we have talked about a lot, Dina, with our young adult patients is the need to instill that sense of independence. And I wonder, as you look back now on your experience, do you feel, and this is, I think, something that will help clinicians who might be, watching this, and Meg, certainly to bring back to the team, is, are we as a team, are our teams, do you think, early enough involving the kids, starting to get their opinion about what they want? It's something that, I've thought about a lot over the years. So I wonder what your thoughts are about that.
Well, I think one of the things that, regardless of what was going on, because there's a lot I can't honestly remember, I think no matter what was going on with the nurses and with the doctors, they always made a point of contact with me, so I knew I could trust them. So even if I didn't always know what was happening, I knew that I was in good hands. And I also think that was helpful because my parents asked lots of questions. So even if I didn't ask, I could hear what was going on. And so I knew a lot about what was, especially with my jaw surgery, coming back to New York and getting a checkup and knowing that it was time for my next big surgery. Just the types of questions that my parents asked and the types of things I learned from that experience in and of itself. Just recently, when I had to do a checkup for the cysts that I had in my face, I was able to ask a lot of questions that I needed answers to. And I also felt comfortable with asking my parents of like, hey, what were some things you asked when you went in to do things? So I know what questions might be more vital. I'd say I feel like everyone I've worked with has just done a great job of making sure if there was anything I needed to do for my surgeries, that I knew what I specifically needed to do to make sure that when I came back, when they looked at my mouth, they weren't going to say, what did you do during the time that you weren't here? So I knew what I was supposed to be eating. I knew what I was supposed to touch and not touch. And so the big questions I knew about. Any little things I learned along the way. I would ask questions when I went back for a checkup, and I knew I could talk to people. So having a safe space where you feel you can trust who you're working with and you can trust what answers they're given opens it up to, if I ever need to ask questions in the future, I know I can, and I know I will get an answer. And that's the best part about the team in New York. Everyone is so willing to talk.
Well, thank you. Thank you for that insight. And I think it's important that wherever you are, whatever team you're working with, that from the very beginning, starting if you're at a prenatal appointment, who's your point person? Who is it that if you have questions that you have that person that's your go-to? I used to be called the air traffic controller for the team. And I think it's very important. Every team has one. And then they can get that question. If it's a feeding or speech, they can get that to Meg. If it's an orthodontic question. So that, that's very, very important. I want to just ask a couple of quick other questions. Dina, just one thing that I thought of is that when Abby was talking about, what, some of the things that she went through maybe at school, I just wonder if you could really quickly just let people know that, we are very aware of that and bullying and teasing and, just something that myFace is doing to try to help with that.
Yes,
just really
so
quickly.
Abby, I could relate so much to what you were talking about, and we actually have, and we went to your school, I remember quite a few years ago, and presented the Wonder Project, which is a program to teach students about differences, choosing kindness, and being an upstander. And so we can definitely go into many schools, both virtually and in person, and we always have support groups as well, virtual, for kids and adults and parents. So we are a resource and support for many.
So I have so many more questions that I could ask, but I think that we're really getting close to being out of time. So again, for anyone who's listening, please, feel free to reach out to myface.org with any of your questions, and I will get them to Meg, to Dr. Flores, to Dina, to the Ruckers. We will, we are here for you. MyFace really wants to help support the work that these teams around the country are doing. So that does conclude our question and answer session. Thank you so much to Dr. Flores, who's stuck in the OR right now, to Meg, to my friend and colleague, Meg Lico, to Abby and Justin and Lori for sharing, your story, and of course to my friend and colleague, Dina. So let me turn it back over
Thank you,
to Dina.
Pat. This was really an incredible presentation. I personally learned so much, and I hope everyone enjoyed the program. I do apologize, as Pat said, we didn't get to all the questions, but if you have additional questions, you can send them to info@myface.org. At MyFace, we strive to provide the most helpful and informative resources. To help us do so, we ask that you take a few moments now to complete a brief survey by using the QR code provided or by visiting www.aoic.net/myface March 5 eval, or scan the QR code on the slide to let us know your thoughts. We will also provide this information in the follow-up email you will receive after this program. Be on the lookout for more upcoming events. And again, thank you for sharing your time with us today. Have a wonderful evening.